Okay, hello. Thank you so much for inviting me to talk today. I'm Miranda Payne. I work in Oxford and I treat almost entirely patients with melanoma. I have a little bit of other skin cancers in my practice. And I've been asked to talk about the updated mucosal melanoma guidelines, which we've been working on the second iteration of recently. So just to sort of set the scene, what I'm going to be talking about, first of all, why do we have separate guidelines? This topic is quite a specialist topic. It's an unusual sort of melanoma. I just want to talk a little bit about why we need to look at it differently from the cutaneous guidelines. A little bit about the guideline writing process, not that you need to know it, but to explain all of the work that went into trying to produce a set of advice that is relevant, that is up to date, and that is based on the facts that we have and acknowledges the gaps that we have. I'm not going to go through the guidelines, so that's not what this talk is. That would be very long. Probably be quite boring. But I will pick out a couple of what I think are the really key topics that are different in mucosal melanoma, just to give you an idea of some of the challenges we have when we meet patients in clinic. And then a little bit about next steps. So super basic, mucosal melanoma, it starts on the mucosa. So I picked the easiest picture to show you of where the mucosa is. But mucosa exists the lining of the gut, in the urethra, in the vulva and the vagina, and in fact in the lining of your respiratory tracts as well. So all sorts of places, and the sinuses. It's an incredibly rare situation, and the incidence of mucosal melanoma is not increasing. The incidence of skin melanoma is increasing. So it's going to become a reducing proportion of the workload we see, but the numbers of patients we see is going to be about static. In terms of why it's different, the first really key thing is location. This is looking at places that you might find a mucosal melanoma. So first of all, in the head and neck, particularly in the sinuses. You can get it in the oral cavity. That is really rare. Anywhere in the gut. And then in the urological sites, so in the urethra and in the vulva vagina. And then there are other rare sites. The really key thing is it often doesn't look like melanoma. So I feel I'm very relieved to sit at the end of the pathway because for clinicians who are diagnosing these types of cancers, it can be really hard. About 40% won't even have pigment. You know, they don't necessarily even look like cancer. They might look like a polyp. They might present with recurrent sinusitis. You might get other symptoms that just don't direct to the diagnosis of a melanoma. And they won't trigger symptoms that mean people see people who are routinely treating melanoma. So patients with a mucosal melanoma might present to the ENT team, they might present to the bowel surgeons, they might be seen in a gynae clinic. And for all of those clinicians, they won't see many patients with melanoma. For me, I find it's quite hard to think what other diseases there are. You know, if I'm presented with somebody, all I can think is this has to be melanoma. But for the specialists that are seeing patients presenting with mucosal melanoma, they might see 1 or 2 patients in a year where that's the diagnosis. The second thing that makes it a tricky cancer, and this is relevant when we talk about some of the surgical challenges, is it doesn't grow like a melanoma on the skin necessarily. So a significant proportion are multifocal. The area of your mucosa will have multiple changes or skip lesions where you might think that you've got to the edge of the melanoma when you're operating, but actually there are changes nearby that are either in situ melanoma or invasive melanoma. So knowing where your tumour is can be really, really challenging. It affects females more than males. That's primarily because of this incidence in the mucosa of the vulva and the vagina. And then the genetics. So I'm going to talk a little bit about the genetics. This is a molecularly different cancer. And that's important because it affects whether you benefit from treatment. So I'll also set the scene in terms of evidence. We love our evidence. When you're trying to write a talk about mucosal melanoma, there's a lot less evidence to show you. And so we sometimes, some of what we do is looking at, well, how is this different from a skin melanoma? So I found a fairly large series of mucosal melanoma samples that had been looked at to look at the genetic mistakes they could see in it. And I'm sure everyone in the room is familiar that about half of skin melanomas will have this very characteristic activating BRAF mutation. The reason we like that is that if it's present, we can do something about that melanoma. We can target it with our BRAF targeted therapy. That is not the story in mucosal melanoma. You have a whole range of mutations that can occur. There's no one that is as common as a BRAF in a skin melanoma. There's about 45 patients, I think, here, and you can see there's an array of mistakes that may or may not be relevant to how that tumour is growing, because just because a genetic mistake is found in a melanoma, it doesn't mean that targeting it will be as helpful as targeting a BRAF in a skin melanoma. The original work was part of a really big project. They had over 2,000 melanoma samples of all sorts, from the skin, from the soles of the foot, from the mucosa, and ocular melanoma, which is obviously another really rare sort of melanoma. And they had a look at all the different mutations to try and work out, well, what is different about non-cutaneous melanoma? And they saw a lower incidence of BRAF, they saw a higher incidence of some other genetic errors, and overall what they saw was a much lower mutational burden. So for all the different types of genetic errors you could get, the incidence was lower in mucosal melanoma. As a group, so this was a different series I found of about 700 cases of mucosal melanoma that had been looked at. The incidence of BRAF seems to be around about 12% in this group. And then the genetic mistake that we look at very often is the c-KIT. And that incidence seemed to be, on average in this group, around about 10%. However, it may be that mucosal melanoma growing in different parts of the body have different patterns of genetic mistakes. So that further complicates it. So in this series, this is all vulvovaginal melanomas, and the c-KIT mutation seemed to be happening in about 1 in 3 people. And when you get an incidence as high as that, you start to think, well, maybe that's something we can exploit in the clinic. For patients with this mistake, is there something that we can target? We do have KIT inhibitors. When we then look at a smaller group of patients with head and neck mucosal melanoma, the incidence of KIT was found to be lower here. And then this is a really small series of patients with oral mucosal melanoma, which is really rare. And again, you can see that the BRAF and the KIT were really uncommon. So it may be that even within mucosal melanoma, we're going to have to look at specifically what is it about this particular case that we can exploit in the clinic. So in terms of writing guidelines, there's a process. I didn't know the process when I started. It's quite a slow process, so it takes about a year from start to finish. It involves meetings, and at the meetings we have everybody we could think of who is involved in the treatment of somebody with mucosal melanoma, including either the patient or the patient representative. So we needed to bring everybody into the room. The really key person, in fact, obviously other than the patient, is a project manager. And the reason for that is that to write guidelines, this isn't about us sitting and just saying what we currently do. It's about stepping back and saying, okay, well, what is the evidence that's out there? And what evidence do we trust? What evidence is good quality? And can this apply to our patients? And so for each theme in the guidelines, we had to write our series of questions. For instance, what operation is the right operation? What treatment is the right treatment? How often would scans be sensible? So you write a question, you then have to define, okay, for that question, Who is that question applying to? What's our comparator? What are the outcomes that we see in the literature? You then go through the literature and you look at every publication that exists related to your question. So there are thousands of publications that you will do an initial screen of, and you then sift out which ones really apply to the population for whom you are writing guidelines. So it is a very careful, very meticulous process, but if it's carried out correctly, and our project manager kind of kept us on track, then you produce guidelines that can be rolled out in a way that we wanted them to be NICE accredited, and they have been. We didn't want to produce guidelines where everyone thought, well, hang on a moment, I'm not sure that's been a comprehensive project to look at what is best for these patients. Once you've done that, you then send them out to even more people. And the word stakeholders, I always find it's not enormously helpful, but basically we send them out to anybody who might have any relevant experience or input about whether these guidelines make sense for them. So that includes patient groups, charities, the Royal Colleges, and for the Royal Colleges, we're thinking about the surgeons, physicians. Primary care is really important because patients obviously will often present via primary care initially. Anybody, the Association of Specialist Nurses, anyone who's involved so that they can sense check, have what we've written, does it make sense for the bit of the pathway that they're involved in? What we absolutely are not writing, and this is really important because it's about how we and you use guidelines. We are like 100% not writing a rule book. That is really, really important. And the reason, obviously, is, just we're all different. And with mucosal melanoma, I have to say that's even more true. Each case, each person, each situation, and each stage of the pathway is different. And it's really important that the guidelines are used as a framework, but in fact, it's and to sort of give the clinician the confidence to ask the trust for the resources, to give patients the confidence to say, well, hang on, what about this? Should I be doing this? Why is this person not involved? But it's not meant to be a list of things that have to happen, because that wouldn't be the right way of approaching what is a very complicated disease and a very complicated set of treatment options. What we did want to do is produce something that was evidence-based. If there's evidence there, we wanted to point it out, and if there wasn't evidence there, we wanted to explain that. There are similarities with melanoma that arises in the skin. That's really important, and we are reliant on a lot of work that's been done in treatments for skin cancer. So we do need to acknowledge that, but it is important to highlight the differences, which is why I wanted to just sort of start with the introduction about why mucosal melanoma is different. I'm trying not to say the word multidisciplinary too often in this. It's obviously the most important word other than patient. So this is really, really importantly about team working. So this is not a linear pathway. What we wanted to highlight in the guidelines is that this is group working pretty much at every stage. There are loads of gaps. So, you do a literature search, you trawl through thousands of publications that involve the word, operation and melanoma, and most of them are not related to patients with mucosal melanoma. Most trials are not related to specifically patients with mucosal melanoma. So the guidelines are there also to promote the idea that we need to have more research at every stage. And ultimately, we wanted to write something that was patient-focused. So just going into the themes, there are 12 themes in the guidelines. Multidisciplinary teams right at the beginning, very important. There is a section on recognition, referral and diagnosis. And then some of the aspects of staging, which is a challenge with mucosal melanoma. We don't actually have a reliable staging system for melanoma that arises in most of the anatomical locations that mucosal melanoma arises in. That's been a problem actually involving patients with mucosal melanoma in trials, because they may not reach the staging criteria for trial, but we know that they're high risk enough to need to be in that trial. And then we started to look at some of the treatment options. We included neoadjuvant therapy, that's treatment before an operation for melanoma. There's no data for mucosal melanoma yet, but it's important to highlight that as a theme because that's very much coming through in cutaneous melanoma. And then we had made some recommendations for research and looked at the whole care pathway. You know, what information is out there and what other support should patients have access to. So I'll just give you an example of how the guidelines are written, partly to highlight how you can spend a whole meeting discussing the word should versus the word could or may. And when you're writing guidelines that you want NICE to approve, those words are really key. So the person sort of guiding us with the process and making sure that we adhered to a very rigorous process that would stand up to scrutiny would encourage us to spend a very long time discussing what did we really want to say should happen and what did we want to say might be relevant. So, you know, these are not, I would say these are not rocket science. I would really hope that patients in my clinic feel they have this, but having it written down hopefully means that if a patient feels they don't have this, they can say, well, look, this has been said, this should be happening for me. So, you know, a named cancer nurse, we would hope everyone has that, and a named consultant, most importantly, knowing how to get hold of them. That is, for me, really, really important. We thought it's really tough if you have a rare cancer. I'm not sure how helpful it is to be constantly told, oh, this is really rare. We didn't want people to be being given information leaflets on skin melanoma and think, well, you know, an awful lot of this doesn't apply to me. So we really wanted there to be literature that was specific to the patient in front of us. And then the next two statements are about access. We want people to be able to access their teams, access imaging if they need it. And as I said earlier, the guidelines like this help us too, because they give us something to take to our trust, to our radiology departments and say, actually, I do need to be able to scan my patients this often. Look, it's written down. This has gone through a rigorous national process. Please, can I have my scans, you know, every 3 months, every 6 months? Just going back a little bit to the pitfalls in diagnosis, which I sort of mentioned, but, you know, mucosal melanoma, we thought it was really important to include in the guideline all the difficulties that can be in diagnosing this because of all of the unusual symptoms that might lead up to the diagnosis and to people being alerted to something being serious going on. So we listed these. Part of this is about guidelines that can then be shown to people further, sort of earlier in the pathway, including people who are unlikely to see more than 1 or 2 cases. So we actually went to district nurses with the guidelines because they do smear tests, not district nurses, practice nurses because they do smear tests, so they may well see vulvovaginal melanoma at a much earlier stage. We wanted them to know that's something you can flag. We went to the colorectal teams and GP practices so that they would know that, you know, actually hemorrhoids that aren't settling might need a little bit of thinking about. 99.9% of cases with the GP will not be a mucosal melanoma, but just for it to be at the back of their minds that there might be something more unusual going on. So for me, if I had to pick one thing that we really, really wanted to get out of the guideline process, it was something written down about surgery that would help patients avoid operations that may not help. You know, everybody who meets a patient with a mucosal melanoma wants to do what they can to help that patient. But because of the location in the body that you get your mucosal melanoma, those are serious and complicated operations, and they're carried out by surgeons who are not part of the melanoma MDT. So they're not routinely seeing patients with with melanoma. These are not dermatologists, they're not plastic surgeons. These might be a bowel surgeon, it might be an ENT surgeon, it might be a gynecologist. And so when you look at the evidence, and the evidence is of, we love our randomized trials, we love double-blind trials, but those don't exist for what surgery should you do in mucosal melanoma. There's lots of series where hospitals have collected patients, sometimes over 20 or 30 years, during which time surgical procedures have changed. But the one message that came through in a lot of the literature was that there is no benefit from very radical surgery for the sake of very radical surgery. And so for us, the questions that we asked at the beginning, setting out for our process of reviewing the literature, was, very focused on what is the right operation, what gets the best outcomes. Key, what margins, lots of discussion about margins with melanoma, what margins should you aim for, and how do you get the best control of that disease. And what's really clear is, what you want is the surgery that you can achieve what we call clear margins. The surgeons call them R0 margins, where they've looked under a microscope, pathologists, and say, look, there's no melanoma at the edges. It's great if you can achieve an R0 margin. But you need to be really careful that you are weighing up, well, what's involved with achieving that R0 margin, and what are the consequences for the patient. And particularly bearing in mind how mucosal melanoma grows. So it may not be a case of just removing a polyp, because there might be changes elsewhere in the mucosa nearby that are also cancer. So you feel briefly better that, yes, I removed the polyp, but what is this a field change? Is there other cancerous cell nearby? We thought it was really important, therefore, that any discussion should be done as part of the MDT, and not the colorectal MDT or the gynae MDT, but an MDT with expertise in melanoma. And that any surgery is performed at a centre where there is that experience at having these complicated discussions, ideally with an oncologist in the room, but that's not always possible, but certainly with an oncologist part of that discussion about, is that surgery really needed? And to give an example, one of the more common sites for a rare cancer would be the anal margin. The anus is essential for continence. So if you are going to remove a melanoma that's on the anus, then in general you are required to remove the larger section of bowel, because you are going to lose bowel continence. And so you end up with a permanent stoma. It's important that patients are given the opportunity to think about what that means. Is that something that is acceptable to them? They also have to have that conversation in the context of the disease. And, I've avoided too many survival curves, but it is important to understand that mucosal melanoma is a melanoma that is still much harder to treat than a skin melanoma. And there are various reasons for that, partly related to late diagnosis. They hide in tricky parts of the body until late, but also because of the biology and because they don't do as well with our medical treatments. And so the last thing we want is to put somebody through a very major operation, and yet they have disease that has spread either already or very shortly afterwards. That absolutely doesn't mean that surgery isn't the right thing. Surgery cures people. That's extremely important. But it does mean that any decision about a potentially life-changing operation should be made with an oncologist who can discuss, well, what are the risks from my mucosal melanoma? What are the other treatments? What will you do if there's a relapse? How will you follow me up? So that they can make that decision. And I have had people have that conversation with the surgeons and with me and say, actually, I don't want that operation. And we choose a different plan for them. So in terms of discussing other management options, surgery isn't the only option, but surgery to achieve complete resection is a really important thing to think, is this feasible? I've highlighted what I've then talked about a lot. There we are. So what it all goes back to is that really at any decision point, what our guidelines want is they want the team back in the room. They want everybody involved with that discussion. And this is where the guidelines can help with hospitals to set up their services, because particularly at the bottom, the site specialist surgeon is not going to be someone who's routinely got time to come to the melanoma MDT every week. They'll only be needed once or twice a year in your centre, but we do want them to join for those conversations about what's right for the patient in that particular instance. The other thing I thought was really important to talk about a little bit was systemic treatment, so medical treatment of mucosal melanoma, because this is where we're doing a lot of extrapolating, really. We don't have lots and lots of high-quality evidence for this situation. Immunotherapy, I'm really glad that Pippa's already introduced it. I suspect you're all pretty au fait with it. The question we asked, this was a really simple question for this section, what is the effectiveness of systemic treatment? That's all we wanted. And there were lots and lots of papers written about systemic treatment for melanoma. There were very, very few written about systemic treatment for mucosal melanoma. Fortunately, some of the larger recent trials of immunotherapy have not excluded patients with mucosal melanoma. So that's been really helpful. It's very difficult when you're setting up clinical trials of new drugs, because you really want to answer the question, does my drug work? And when you have a subgroup of melanoma that you predict it will work, our current treatments work less well in, if you have a trial with only 30 patients, bottom line is you don't really want 4 or 5 of them to have mucosal melanoma, because your chance of answering your question, does my treatment work for all melanoma, is reduced if a significant number of people in your trial have a type of treatment that's likely to be resistant. So a lot of the smaller trials will say, actually, we don't want patients with mucosal melanoma in our trial. But some of the larger trials will, and that's great. When you have a trial with almost 1,000 people, it's okay to have some patients with mucosal melanoma, and you might even get enough evidence to say something about this subgroup. So what a pooled analysis did was they looked at 6 trials in which patients had been treated with checkpoint inhibitors, 2 of which had been treated with combination ipilimumab-nivolumab. And these were high-quality trials. They were randomised. They were double-blind. It includes the Checkmate 067, which Pippa showed you the 10-year data on. You then have a kind of pooled analysis of lots and lots of patients. However, we still only had in there 85 patients. Out of all of those trials, only 85 had a diagnosis of mucosal melanoma, and of whom only 35 patients were given combination ipilimumab-nivolumab. So you can see, this is the kind of level of evidence that you're having to make decisions on in the clinic and discuss, well, what is my chance of benefiting from immunotherapy? We know immunotherapy can work in mucosal melanoma, but we are basing that on personal experience and very small numbers in pooled analyses. Oh, gone back up, sorry. So, based on what we have, we think that combination immunotherapy with IPI and Nivo, I can't just say combination anymore, can I? Because there's another combination, is probably about 40%, around about that. And for single agent, it's probably about 25%. So that's less than for patients with metastatic cutaneous melanoma, but the chance of long-term response is still there. So these still remain the first choice treatments for patients with mucosal melanoma. The nivolumab relatlimab is the new combination that was approved last year. It's a combination of 2 checkpoint inhibitors. So you've still got the old friend nivolumab, the anti-PD-1, but this time with a LAG-3. All credit, they didn't exclude patients with mucosal melanoma. The number was really, really small. So small that I can't see it with my 50-year-old eyes, but it's single. So when they then, we know that nivolumab relatlimab, which is the upper curve here in the blue, works a little bit better than single agent, but you really can't interpret what that means for patients with mucosal melanoma. because the numbers are so small. However, the prediction would be that it would work, maybe a little bit better than single agent, but not as well as combination ipi-nivo. In terms of other options, the story is not as encouraging for targeted therapy as with cutaneous melanoma. We haven't got our reliance. We absolutely mustn't miss the occasional BRAF mutation. It's really important if you have mucosal melanoma, you know, do I have a targetable BRAF mutation? Because if you do, that's really key information right from the beginning. The KIT mutations, it's not one typical characteristic mutation. So it's a bit of a mixed bag, some of which are targetable, some of which are not. There seem to be 4 mutations that are slightly more common. It's an unlicensed indication, but actually we can access imatinib and other KIT inhibitors relatively easily. And there are case reports in the literature of long-term responses, but not very much like BRAF MET, where we do expect the melanoma to develop resistance at some point. Clinical trials is really important. You know, if you have a mucosal melanoma, it's really important you know what trials are out there at the moment at every decision point in your treatment. And the Target National is an example of a trial that's trying to look at, does your cancer, of whatever kind, have something that we can exploit for your treatment? And then whether there's a role of whole genome sequencing, which is now approved on the NHS for patients with no remaining standard of care. It's tricky. It's a very slow test where you send off fresh tissue, you won't get any results for 3 months, and then you get a huge amount of data back about your cancer. And your clinician will have a meeting with the genomics MDT, and they will talk through lots of things that very difficult to understand, lots of pretty pictures that I don't follow. The bottom line is that it is actually quite rare to find something that you can immediately exploit with a treatment that exists. And even if you find something that you think you might be able to treat, you might not be able to access that treatment. But it is information about your cancer. And I think for a cancer where we don't have much information, then getting as much data about your own tumour so that your treatment can be as personalised as possible, the better. So, in summary, I really hope that I've explained why mucosal melanoma did need separate guidelines. I've explained a little bit about the guideline writing process so that you know that you're not just reading somebody's idea of what they like to do in their hospital. I've given you a couple of examples, but there are lots more, and the guidelines are accessible on the Melanoma Focus website. And then we've talked a little bit about next steps. But the big message really is team working and research. And I think we're doing questions at the end.